You've probably heard the term heart attack a million times, but what you might not know is that it's just one part of a much bigger, more urgent story that doctors call acute coronary syndromes. In this explainer, we are going to dive deep into that story, all the way from how an artery gets clogged in the first place, right up to the moment of diagnosis in the ER. All right, here's our game plan. We'll start by looking at the whole spectrum of heart attacks. Then we're going to zoom all the way into the microscopic level to see how a clog actually forms. After that, we'll jump over to the clinical side of things, how doctors investigate, what they look for in the blood, and how they classify these events. Let's get into it.
So first things first, let's talk about the big picture. This term, acute coronary syndrome, what does it actually mean?
Okay, so the first thing to know is that acute coronary syndrome, or ACS for short, isn't just one single thing. It's really an umbrella term. It covers any situation where the blood flow to the heart muscle suddenly drops. Now, when that muscle is starved for oxygen, we call it myocardial ischemia. You can think of it as the muscle gasping for air. And if that goes on for too long, well, that muscle tissue actually starts to die. And in medical terms, that's called necrosis.
This whole spectrum really boils down to two key questions. How bad is the blockage, and did it cause permanent damage? So over on the left, you've got a partial blockage. This could be unstable angina. That's chest pain from a clog that's just temporary and doesn't leave any lasting damage. But if that partial blockage sticks around long enough to actually kill some heart muscle, it becomes something called an NSTEMI. Now on the other side of the coin, if you have a complete 100% blockage, well, that's a STEMI. That's the big one, and it causes a lot of damage. The level of blockage is what tells us everything about the diagnosis and how urgently we need to act.
Okay, so we know what happens. But how? How does a perfectly healthy artery suddenly get blocked? To get that, we need to look at the chain reaction that causes this tiny plumbing disaster inside the heart. It almost always kicks off with something called atherosclerotic plaque. Just imagine, for years and years, cholesterol and other gunk slowly builds up on the inside of the artery wall, kind of like rust in an old pipe. Most of the time, this plaque is stable. It just sits there. But if the thin cap holding it all together gets weak and cracks open, it exposes all that inflammatory stuff inside to the bloodstream. And that single moment, that rupture, is the spark that lights the whole fire. The second that plaque ruptures, the body's internal alarm system goes off. It sees this as a major injury that needs to be plugged, and it needs to be plugged now. So it sends in the first responders. These tiny little things in your blood called platelets. They just swarm the site of the injury, they get all sticky, and they latch on to that exposed plaque. And as they do, they start sending out chemical signals, basically screaming for backup.
And this is where things really ramp up, fast. That exposed gunk from the plaque releases a chemical called tissue factor, and that sets off a massive chain reaction known as the coagulation cascade. Seriously, it's just like tipping over the first domino. One thing triggers the next, which triggers the next, and the final domino to fall is a super powerful enzyme called thrombin. Its whole job is to build the final, stable clot.
So here's the last step. Thrombin acts like an emergency foreman on a construction site. It grabs a protein that's just floating around in the blood, called fibrinogen, and it weaves it into this sticky, strong mesh of fibrin. This fibrin net is like the rebar in concrete. It wraps around all those platelets, traps even more blood cells, and turns a temporary plug into a solid, immovable blood clot. We call that a thrombus. And just like that, the artery is blocked, and the heart muscle downstream is now starving.
All right, we've seen the disaster unfolding at the microscopic level. Now let's pull the camera back and jump into the real world, into the emergency room. When a patient comes in, how do doctors even start to think that this might be ACS?
The textbook symptom is that classic crushing chest pain, maybe spreading to the left arm or the jaw. And yeah, that definitely happens. But here's what's so important to know. Not everyone gets that. Some people, particularly women or patients with diabetes, might only feel really short of breath, or break out in a cold sweat, or get nauseous, or feel a kind of fatigue they've never felt before. We call these anginal equivalents, and they are massive red flags.
Whenever ACS is even a possibility, there's a phrase that every doctor knows: time is muscle. Every second that ticks by, more heart muscle is at risk of dying. That's why the rule is ironclad and non-negotiable. You get an ECG on the patient within 10 minutes of them showing up, period. It is the absolute first, most critical step.
And this is what we're looking at. The ECG is basically a readout of the heart's electrical activity.
What doctors are searching for in all those squiggly lines are very specific patterns. Patterns that scream, hey, this part of the heart muscle isn't getting enough oxygen. It's the primary tool that lets them sort patients into the right treatment pathway, and do it fast.
But as critical as it is, the ECG is just one piece of the puzzle. It tells us the heart is in distress, but it doesn't prove that muscle has been permanently damaged. For that smoking gun, we have to go to the lab and look for evidence in the blood. That brings us to cardiac biomarkers.
The key blood test here is for a protein called cardiac troponin. Now, think about it like this. Troponin is supposed to live exclusively inside your heart muscle cells. It shouldn't be just floating around in your bloodstream. So, when those cells die from the lack of oxygen, that necroses we talked about, they break open and spill their guts, including troponin, into the blood. So if we run a blood test and we find troponin, that's it. It's the fingerprint. It's the definitive proof that heart muscle cells have died.
And this right here is where troponin becomes the star detective. Remember how unstable angina and an NSTEMI can look super similar at first? Same symptoms, maybe a similar ECG, both from a partial clog. So how do you tell them apart? Troponin. In unstable angina, the heart was stressed, but no cells died, so the troponin test is negative. But in an NSTEMI, some muscle did die, so the troponin test is positive. That one blood test is the line in the sand between a temporary scare and a confirmed heart attack.
So we've been throwing around terms like STEMI and NSTEMI, but cardiologists actually have a much more formal system for classifying these things. It's called the Universal Definition of Myocardial Infarction, and it breaks heart attacks, or MIs, into 5 different types based on what caused them.
The 2 you'll hear about the most are type 1 and type 2. A type 1 MI is the classic event we've been describing this whole time. A plaque ruptures, a clot forms, it blocks the artery, it is a plumbing problem. A type 2 MI, though, is completely different. It's a supply and demand problem. Here, the artery itself might be fine, no new clot, but the heart is working so incredibly hard, maybe from a severe infection or a crazy fast heart rhythm, that it demands more oxygen than the arteries can supply. And the difference is critical, right? For a type 1, you treat the clog. For a type 2, you have to treat the underlying thing that's making the heart work so hard.
The other types are much more specific. Type 3 is what's used when a patient dies suddenly from a suspected heart attack, but before any blood could be drawn for tests. And then types 4 and 5 are both related to medical procedures. Type 4 is a heart attack that happens in connection with getting a stent put in, and type 5 is one that's associated with having coronary artery bypass surgery.
Whew! Okay, we have covered a lot. Let's take a breath and put all the most important pieces together.
So if you remember one thing about how ACS is diagnosed, remember this triad. It's like a 3-legged stool. You need all 3 legs for a stable diagnosis. First, you have the clinical presentation. What's the patient's story? What are their symptoms? Second, the ECG findings. What is the heart's electrical system telling you? And third, the cardiac biomarkers. Is there cold, hard evidence of muscle death in the blood? You have to evaluate all 3 together to really see the full picture.
And why does this matter so much? Because this isn't some rare disease. We are talking about around 1 million hospital admissions for acute coronary syndromes in the US every single year. 1 million. Understanding this is absolutely critical.
And looking ahead, after someone has a heart attack, their long-term outlook depends on a few key things. Probably the single biggest factor is their left ventricular ejection fraction, or LVEF, which is just a fancy way of saying how strong is the heart's main pump now that it's been damaged. Of course, other things are huge too, like the patient's age, whether or not they have diabetes, how well their kidneys are working, and just how severe the heart attack was to begin with.
So, we'll leave you with a question to think about. Our ability to diagnose heart attacks is getting faster and more precise all the time, especially with these new, super-sensitive troponin tests. We can spot damage quicker than ever before. So the big question for the future is, how will our treatments evolve to match that precision? How can we start personalizing care for every single patient?